So we're very pleased to have this terrific audience. Excuse me, you are a terrific audience, but it's a terrific panel to talk to this terrific audience about methods. And my co-panel moderator is Rita Hamad. Rita is a physician and economist based at the Institute for Health Policy Studies and Department of Family Medicine here at UCSF. Recently did a stint down at Stanford, and so she's kind of representing some critical parts of this group of institutions. We're very happy to have her here to lead us through the methods discussion. Rita?
So welcome, everybody. We have a great set of speakers, and I don't want to take up too much of the time that they're going to need, so we'll start off with Dr. Sanjay Basu, who's an assistant professor of medicine at Stanford. He's a primary care physician and epidemiologist. His research is on health and social policies and how they might reduce morbidity and mortality from cardiovascular disease. He's uses methods in computer science, econometrics, and biostatistics, and he's the director of analytics and the analytics and modeling core of Stanford's Precision Health for Ethnic and Racial Equity. We're very pleased to have him today. Sanjay.
Good morning. It's nice to see everyone. It's a privilege to talk to you this morning. I wanted to talk about one methodological approach that I found particularly useful recently, and I have to thank my colleague Jay Bhattacharya for introducing me to it. It's known as bounding methods or boundary solutions, and it's not actually innovative. It's quite old. Some of you might have encountered it in other contexts, but there's been a resurgence in its use, and I'd like to talk about it by way of example. The example I used was a request from the UN Relief and Works Agency to estimate the impact of unenrollment from one of their programs. So the UN Relief and Works Agency provides healthcare as well as nutrition support services to a relatively large population of registered refugees in the Middle East, about 5.3 plus million people. One of their programs, upon interaction with the White House, as you might have read recently, has effectively been defunded, and the strategy was to provide fruits, vegetables, and legumes to various refugees, and they needed to cut their budget dramatically. They wanted to estimate, or they wanted us to estimate, what the impact of disenrollment or unenrollment, whatever the correct word is, would be on some nutritional metrics. Part of the desire was not simply to understand the health effects or nutritional effects of this program, or removal from this program, but also to understand how other UN agencies might be able to augment the services or shore up the problem. Now, of course, this, like many evaluations of social safety net programs, could not possibly ethically be a randomized trial, right? To truly get the effect of this program or disenrollment from the program, we'd like to do randomization to correct for the profound selection bias of who gets unenrolled. In this case, it was decided after much politics that the unenrollment would proceed as follows. People would have to recertify through some rather intensive recertification programs. Those who didn't end up getting to recertify would be automatically unenrolled. And much high-quality ethnography suggested that those most vulnerable, using the definition of vulnerability just given to us, were those who were being unenrolled. So there's profound selection bias, and who is actually unenrolled can't be fairly compared to those who remain enrolled, and yet we can't do a randomized trial to estimate the impact of the program. This is not an atypical situation. When using observational data, in this case we had health surveys and nutritional surveys among the people over time, those while they were still enrolled and those after disenrollment, as well as those who remain enrolled. We have the usual panoply of anxieties about using this observational data, which we typically don't relate to people in the policy conversation but have in gatherings like this. There are numerous estimates, some people typically just comparing the outcomes among those unenrolled versus those enrolled. Concerns about reverse psychology, reverse causality, maybe reverse psychology too, in which people who are sicker are those who are getting unenrolled in the program, maybe vice versa. Some people have done instrumental variable analyses, which you'll talk more about. with the problem being that those instruments, factors that may influence you into the program and by that pathway only influence the outcome, might not be as good as randomization. And of course, huge nonlinear responses. People who are very vulnerable might have much worse nutritional effects than those who are just, marginally qualifying for the program and hey, they got a little bit extra support, but it's not the end of the world. And we want to understand that. So here's my question. Some of you know I'm a bit of a pessimist. Why not just give up? So in this context, I'm going to limit my why not just give up to why not just give up on point estimates. The idea being, so for example, in my field of epidemiology, all day long we try to control for as many confounders as we can and get from X to Y, in this case from program participation to some metric of nutrition. And we bend backwards in order to try to say that we've addressed various factors. Popular in our field, for example, is propensity score matching, where we try to put every imaginable covariate in and imagine that we aren't left with anything that influence program participation, which is a horrendously unbelievable assumption, right? People's life histories, their families' interaction with the UN program office, violence in their neighborhood, all factors that are not in our surveys are influencing whether or not you remain enrolled or become unenrolled in this program. And yet we are going to assume away for a moment that that's not the case and come up with some estimate of effect and 95% confidence intervals that are probably unbelievable. So I'm going to ask you to suspend disbelief in your statistics regression class for a moment and say, give up on it and do something else. It's kind of like this image from XKCD. Those of you who are PhD students probably frequent this site. Here's a cautionary vision of things to come. This is the future, and this is the future if you give up the fight over the world literally, which I have to do with all undergraduates, I find. They look exactly the same. So here's the idea behind bounds analysis. What we do is on the left. We do a multivariate regression, propensity score analysis, whatever fancy approach. We come up with a point estimate and some confidence intervals. What I'm hoping to show you is a completely alternative approach, which you can do on pencil and paper sometimes, which is to forget about the point estimate for a moment and just find within reason, and I'll hope to convince you that sometimes it can be very reasonable, what might be the biggest impact to your program and the lowest impact to your program. And then add assumptions that in many cases are much more testable than the assumptions we use. And by adding that, we're going to shrink down those bounds, which in some cases, but not all, may help us better estimate the effects of a program. Some of the times when this is nice is when some of those parametric assumptions are particularly problematic that we use in epidemiology. So for example, the idea of linear response. Some of the assumptions that we often have with matching that are really undefensible, like that we've accounted for every imaginable factor and there's no unobserved or unmeasurable factors leading to selection bias. And what's really nice about bounds analysis is you avoid some word salad that you end up with a lot of matching or instrumental variable estimations. Is it the average treatment effect on the treated, a local average treatment effect, blah, 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 blah. And you end up not being able to generalize your conclusion. This is just getting the treatment effect, the average treatment effect. So here's how we start. Suppose we have some outcome, y. And Dr. Khan made me cut out tremendous numbers of equations from these slides, so this is it. Suppose this is your outcome given your exposure. So either a 0 or 1, right? 1 if you're unenrolled, and 0 if you're enrolled for this particular example. Where is your treatment effect? Okay, in the worst possible scenario, let's say, is there a pointer? There's a pointer, cool. Oh, come on. So there's a lower bound. Like, what is the worst possible health you can get if you're disenrolled? What's the best possible health you can get if you're enrolled? And then the opposite. Your treatment effect has to be somewhere in there, right? So you can do this observationally and say, oh, what's like the best observation among everybody? What's the worst observation among everybody? And you're going to get some really, really wide bounds. But let's start there because that's like very believable. It's the basically from 0 to infinity or from 0 to 1 possibilities. But watch what happens if we can decompose this. Suppose, so law of total probability for the students out there, suppose you take each of these outcomes. Like, what would be your outcome on average if you were unenrolled? What would be your outcome if you're enrolled in this nutrition program that gives you fruits and vegetables and legumes? you can break it down. You know that it has to be, if you're calculating some averages, the proportion of people unenrolled times their outcome. Well, you have that observed. Plus the proportion of people enrolled times their outcome if they had magically been randomized to unenrollment. That's the problem, that part in blue. We can't observe that, right? This is the fundamental problem of causal inference. So suspend disbelief and just say the part in blue is the part we can't observe right now. What about the outcome if enrolled? It's just the converse. Who's enrolled? What's their outcome? We observe all that. Who's unenrolled? What would have been their outcome of the unenrolled if they had been enrolled? That's the problem. So it turns out we can estimate most of these quantities just from, looking in Excel and saying what are the proportions of people and what are their outcomes. It's the parts in blue that then we can bound. We can say what's the worst possible and what's the best possible for each of these with very reasonable assumptions that you really need to just reason through rather than doing any kind of calculations. And most often this type of analysis is useful if you can do at least two, but usually all three of these assumptions. So I'm going to explain each one of these in turn and then give you intuition based on my example. So the first one, and of course because this was in the econ literature, they came up with like ridiculously complicated ways of saying what the term is, but it's actually quite straightforward. So the first assumption, monotone treatment selection. What this basically means is what is the direction of your selection bias? So we had really good evidence from ethnography that the people who are getting unenrolled for this particular program are negatively selected, meaning that they're either on average just as well off as the enrolled or worse off. So how does that help us? It helps us by saying back in that first equation where you have the upper lower bounds on either side, you can say those unenrolled have to at least meet the average or be worse health in every possible scenario for Y1 and Y0 calculations. So you go from your worst case scenario, every imaginable possible health you observe in your data set bounds, to something that is tighter. And then you can tighten it even more. It's this iterative process. Monotone treatment response, another clunky term. This is about the action that happens to people. In this process, the getting of unenrolled, you assume does not improve your outcome. What's nice about this assumption is it's very testable, right? We saw the people who were enrolled, we saw them getting unenrolled, and we saw their survey outcomes. So you can reject this assumption if it's not reasonable. In our case, it was very reasonable. No one, basically, actually improved in their nutritional outcome, which in this case is something called a healthy eating index. It's like an index from 0 to 100. And you can tighten those further. Now your bounds are going to be ranging from the observed mean difference to 0. And so that you might think doesn't help you very much with just MTR alone, but the reason that you add it is you can combine the first two assumptions, and now you've narrowed your bounds even further. And here's where bounding analysis is particularly conceptually a little hard, but I've tried to boil it down, is if you have an instrument. If you have some factor out there that pushes people differently into your program. So for example, some districts who are doing this unenrollment, in order to get re-enrolled, it's like a bear of a process. You have to go through tons of paperwork. You get fingerprinted and confirmed in a million different ways whether you're really a registered refugee. They have to it's kind of like going to the DMV, right? It's like very discouraging against getting enrolled. And then there's others. I always now that I have a kid, I see Zootopia like every weekend, and it's like the sloths in the DMV scene, so it's very difficult. Parents know what I mean by that. And other districts are really efficient. In fact, they're so much even more efficient than some US-based re-enrollments. They have this camera imaging technology so that even if you're not literate, you can basically get re-enrolled instantly. It's very impressive. So this is an instrument. This is pushing some people in some districts who would not get through the paperwork into being able to re-enroll quickly. In other districts, it's a total bear. You can basically tighten your bounds even further by looking across the spectrum of this instrument, of the hard places to the easy places, and saying at each point, what are the bounds within those values of the instrument? And use the tighter bounds as a step function. You could say, hey, the improved place should have at least as well as the prior worst place. And by stepping it up across, there's some interesting things. You don't actually need as strong as an instrumental variable as what my colleague will discuss with classical instrumental variables. It doesn't have to be strictly causal or strictly monotonic. But it lets you bound, when you combine all these three, around a much tighter width interval of where your estimated effect might be. In this particular case, with the bounding approach, we found some worse health if unenrolled. It wasn't surprising, but the quantities helped the UN estimate the degree to which they were seeing worsening health and whether or not some other programs might be able to patch in. Interestingly, if you just did standard statistical regression and corrected for everything, it was like kind of a null effect, and it was really wide in terms of the confidence intervals. It wasn't a very helpful result. I suspect that they were actually maybe overcorrecting because they corrected for things like income, which you can imagine might be on the pathway between program unenrollment and the outcome, and so maybe a little overcorrected. But regardless, it was an unhelpful result from least squares. What's interesting is, in the past, there had been a randomized trial when the program was first introduced. They had randomized some communities and not to getting the program. That's not to say that it's necessarily going to always have the opposite effect when people are unenrolled, since you might imagine it might be even worse, or you can make various arguments. But it is notable that it was the opposite sign in roughly the same direction. So, bounding techniques might have some less severe and, in some cases, testable assumptions to estimate effects. It's not very intuitive when you're trained so much in statistical regression, but in some ways, it's actually easier and almost more of a pen and paper technique than some of the more complicated approaches, and can be particularly helpful if you have a lot of selection problems and the right scenarios in which these assumptions might be reasonable. I'll end by giving you some potential papers that I liked that demonstrated this in a way that I found intelligible. And there is some software, particularly in Stata. This is now a built-in function. And given that this is an ongoing discussion, I left you with this cartoon that I think will help provide tension and annoyance. Thanks.
All right, thank you, Sanjay. So we're going to do questions at the end, so we're going to go on to our next speaker. This is Will Dow, who's a professor of health economics at the Berkeley Center on Economics and Demography of Aging. Will's research analyzes the economic aspects of health insurance, health behaviors, and health and demographic outcomes. And today he's going to be speaking with us about conjoint analysis for measuring family planning provider bias against youth clients.
So thank you so much to Jim and Kazi and everyone for inviting me to give this talk today. As Sanjay alluded to, we were asked to give talks that didn't have many equations, and Sanjay did an excellent job of actually explaining a difficult technical concept without a lot of equations, and I just punted. I said, well, I'm not going to be able to do that. I confess, what I'm going to give a talk on is something that I actually don't know a whole lot about, and that's conjoint analysis, because it's a lot easier to give a non-technical talk about something in which you're not an expert. But when Jim made the ask, I happened to be doing a project that involved conjoint analysis that I thought was actually a very apt application for conjoint analysis. And it's a technique that some people out there think has been overused and is completely unreliable, and other people would argue, well, it actually could be used a lot more in the right circumstances. And so I thought it would be a useful technique just to sort of give an example of where I think that it's actually been super helpful. So I am going to do the normal boring outline where I'll motivate this and tell you a little bit about the conjoint analysis, but without any equations. I'm just going to wave my hands a couple times. And then I'll show you some data and some preliminary results from this project that we're involved in. So what this project is looking at is family planning, and as everyone in this room knows, there are areas of the world, particularly in sub-Saharan Africa, countries like Tanzania, one of the countries we're studying, that have still very high fertility, high unmet need for family planning, and this is particularly a concern among youth. And in many ways, we think youth are a particularly vulnerable population, and it looks like the systems have been not serving youth very well, okay? So there are a variety of different biases that people have talked about, that providers may be biased against providing family planning to youth. So it may be that just the youth are too time-consuming to counsel, is one of the things that we've heard in some of the sort of formative qualitative work that we've been doing in this project. Another is that family planning is going to promote promiscuity. among youth, and this particular concern among unmarried youth. Or another concern is that family planning may interfere with certain pronatalist aims and norms in some of these communities, so among these these married youth. So what we're looking at is trying to measure the extent to which providers do appear to be discriminating against youth clients, but in particular because of their youth. And what we want to distinguish is discriminating against these youth clients because of their youth versus discriminating against them because they may be unmarried or they don't have any children among those that are recently married. Right? So those are very different populations. And in the discussions around youth bias, they generally haven't really distinguished between those well enough. Now, there are a bunch of different methods out there where you could look at this, okay? So it would be great if we had patient-level interviews that were very detailed, have these exit interviews with thousands of patients, and we can try to parse this out through some kind of regression methods. That's really costly. We don't have those kinds of data in a lot of places. We could try to observe patient visits, Hawthorne effects. Standardized patients is something that has been done. But you're limited to only looking at certain types of non-intervention and counseling types of things. I mean, you can't send in a standardized patient and see whether they get an IUD every time, right? I mean, it just doesn't work. So what we have is provider-level data in many cases that people have developed, but we know there's a lot of desirability bias if we just go in and ask a provider, what are your attitudes towards serving youth? So what we're looking at is to the extent to which something like conjoint analysis can help in this case. All right, so what is conjoint analysis? This is where I start sort of waving my hands really quickly. For those of you who know what it is, you're going to say, well, that's not a very good explanation. Those of you who don't know what it is, you're going to still scratch your head. But this is a stated preference method to elicit preferences over product attributes. What does that mean? So it's been used in market research, is one of the canonical applications, where you survey consumers to ask what types of products they would like to buy among a set of products with different attributes. So for example, let's say that you're selling cell phones, and you can give these consumers examples of different products with different sizes, different screens, different camera qualities, etc. And then this is a way of sort of putting together these questions and then statistical analyses to try to understand which of those product characteristics were actually most important in driving the consumer's behavior. Okay, so there's well established. What we're going to do is adapt this for thinking about provider bias. So in this case, instead of consumers, we're going to be asking providers. And we're going to be asking them questions about how they would treat patients with different types of attributes. So we're going to ask them about how they would provide, what types of family planning they would provide to these hypothetical clients. And we're going to experimentally vary the types of clients that we are hypothetically presenting to them based on their age, and their marital status, and their parity in particular, to be able to parse these out. And then typically there's some kind of sort of conditional logit or mixed logit type of estimation to sort of infer those attributes. I'm going to give you a very simple example that doesn't involve a lot of sort of fancy regressions, actually. So this is part of a larger project that the Gates Foundation funded. Pathfinder is the prime. At Berkeley, SIGA, a group of us in the Behavioral Economics Reproductive Health Initiative, were asked to be involved in this from a sort of evaluation perspective. It's building on the Adolescent 360 project. For those of you who may know that the Gates Foundation is funded to try to improve sort of family planning for youth, and we're looking at the provider side. So as part of this project, we did a survey of sort of 800 or so providers in the 3 countries that we're working in: Tanzania, Burkina Faso, and Pakistan. Very different sort of social norms and systems in these different places. But we asked the standard questions on provider reported, so what their knowledge is, what their attitudes, what their practices are towards youth clients. And this is where we worry there's a lot of desirability bias, but we wanted to start in the baseline there. Well, what do they tell us? And that was really interesting. I'll show you some of those results. And then we had this conjoint questionnaire. And we asked them lots of questions. For example, would you even counsel this hypothetical client, or would you refuse to counsel them? Would you provide them with modern methods? And so we varied the clients between ages 15, 20, 25, unmarried, married, parity 0, 1, or 2 plus. So we have a total of 18 different potential hypothetical clients. With each provider that we interviewed, we only asked them about 3 potential clients. I mean, it's just overload to ask them about all these different types. So for example, we said, well, here's a client who's 15 years old, unmarried, has no children. Let's talk about what it might be like if she came in today to ask for services. So the client is interested in learning more about different family planning methods. What's the next step? Before you even begin a consultation, would you just decline counseling? Would you ask them a bunch of questions? Would you offer counseling? And then we ask them questions such as, would it be appropriate to provide modern methods of family planning to this client, such as injectables, pills, or implants? And so yes, no. All right, so that's the types of conjoint questions, very sort of straightforward. The few characteristics on these providers themselves, most of them are not youth themselves. Some are sort of younger than others. There's a spectrum across the different countries and the extent to which they're sort of Muslim or sort of other religions. A lot of them do say that they are counseling youth. They see youth in their practices regularly, but in Pakistan that's less likely to happen, that they're seeing youth 14 to 18, even though we know that marital rates are so high among youth 14 to 18 in Pakistan. Okay, so just to start with, I'll show you some basic results from these sort of self-reported, what providers are actually telling us when we ask them. So according to your own religious beliefs, is it acceptable to limit contraceptive options to youth clients? And we see that in Tanzania, about half of them, Burkina, about half of them say yes. Pakistan, about 80% of them say, well, it would be acceptable to limit contraceptives to youth. And we didn't say what type of youth, right? This is the difficulty in asking these types of questions in a questionnaire. So at the bottom of this slide, I won't go through all of these. In the bottom half of the slide, we tried to combine age with some other characteristics of these youth. So we talk about young couples should have children as soon as possible after marriage to get at these pronatalist attitudes. And this varied a lot across the different countries, but the majority of providers in Burkina Faso and Pakistan had these sort of pronatalist types of attitudes. So we have a lot of mixed evidence from this study and from other studies out there about how to interpret this, whether there's actually going to be sort of bias in the actual behavior that the providers are seeing these clients. And we were, again, really interested in unpacking, is it the youth itself or is it some other characteristic of the youth? So here's what we get when we did the conjoint questions about declining provider counseling. And I'm going to show you results from, these are essentially marginal effects on the probability of declining counseling from underlying regression model. And when we look by age, this is pulling across all 3 countries now, we see that about 19% overall say that they would decline counseling across all these different types of clients that we hypothetically gave them. But it doesn't vary by age at all in this multiple regression. Once we're controlling for marital status, so being unmarried is what's driving it, and parity. So it's marital status and parity which look like they're driving these decisions around provider counseling. Now this is going to vary a little bit across country. So in Tanzania, these effects, there's sort of no age gradient. The effects of parity and marital status aren't all that big. In Burkina Faso, actually all the providers said that they would provide counseling. There's nothing interesting there. And then in Pakistan, that's where the results are being driven. Really big effects for unmarried and nulliparous women. If we then look at denying modern methods, we get something very similar. Okay, so for denying modern methods, again, it's not the age which is doing it, it's the marital status and the parity. And again, if I break these out by country, now in Burkina Faso, actually there is something a little bit more interesting going on. It looks like the nulliparous women are about 20% percentage point increase in the probability of being denied modern methods because they're nulliparous, not because they're young. There's no relationship with age. And then in Pakistan, again, there's these huge effects based on marital status and parity, but it's not the age which is doing it. So, just to summarize, again, these standard questions where we ask the providers, again, in these very difficult ways of trying to ask these providers these sort of different types of questions in a standard questionnaire, it seems to reveal this really strong youth bias. But when we try to unpack that using the conjoint method in this case, it looks like it's not the youth at all that's causing the bias, it's the marital status and parity. So the implication, first of all, for the project that we're doing, trying to design interventions as part of this Beyond Bias project, we're going to have to design our questionnaires a lot better to parse this out, because it just hadn't been on our radar in this way at all when we started the project. People told us, well, there's this whole evidence that youth are being biased given poor care, and there's bias against them, so design an intervention to deal with that. Well, that standard questionnaire wasn't very useful, it turns out. And when we go and design that intervention, just focusing on youth bias may just be the wrong target. So we did a whole lot of formative work early on before we had these results, trying to understand the provider's interpretation of what it's like to be a youth. But no, what we really need to focus on is their attitudes and practices towards unmarried and nulliparous women. So, again, thank you. I think this is a really interesting type of example where we can use these methods to unpack these types of biases and understand, well, what aspects of these populations are really causing the vulnerability when we're seeing people sort of get poor care. So, thank you so much.
All right, thanks, Will. I don't know about you guys, but I'm a methods nerd, so I'm just trying to think of all the different projects I have and how I can apply each of these methods, which are maybe not new time-wise, but feel like they're being innovatively applied to these problems. Okay, so next up we have Joshua Solomon, who's a professor of medicine in the Stanford Primary Care and Outcomes Research Center. He directs the Prevention Policy Modeling Lab, which is a multi-institution research consortium that conducts health and economic modeling with the CDC to inform prevention and treatment policies for infectious disease. He's going to be speaking to us today on pitfalls in modeling targeted strategies for infectious diseases.
Good morning, everybody, and I'm delighted to be here, so let me thank the organizers for inviting me, and thank all of you for joining us today. I should say, actually, that when Jim first contacted me about participating in this colloquium, I was flattered and excited, but I said to Jim, I don't know anything about vulnerable populations, so maybe I could managed to moderate a session, and then at least I could learn something. And Jim said, great, let's do that. And then, a couple months pass, and I get the program, and I'm on it to give a talk, and now I understand that I've been demoted. Yeah, exactly. So with that in mind, let me also mention that unlike the two excellent talks that have preceded, I will not be talking about a specific method and its exposition through application. What I will be doing is giving you a somewhat broader survey of the area in which I work, which is a lot of mathematical modeling and economic evaluation. And I'll be coming at this from a perspective of sort of growing discontent. And if that sounds not that fun to you, let me assure you that I will try to bring this around to slightly more optimism towards the end. So sit back and enjoy. Let me start a little bit broadly with an observation, and that is that every year, as many of you know, there are literally, I think that's correct actually, there are literally hundreds of cost-effectiveness analyses that are published. And you can see here, these are charted over time by Peter Newman's group at Tufts. And I've split out the high-income versus the low- and middle-income country, but kind of growing numbers in both cases. But you're hard-pressed to find too many examples of all of these analyses actually translating into changes in policy. And that's especially true outside of rich countries where there are some examples. And so a question that has been motivating me over the last several years is why this contradiction? And I think there are several reasons, but let me focus just very briefly on what I think are a couple of the more important ones. The first one is that many cost-effectiveness results just seem too good to be true. So here are some vintage examples from HIV prevention and treatment, which is an area in which I work. And if you look at these, they suggest extraordinarily high value for money based on all of the commonly used benchmarks that we would apply. For as little as $1, you can add 1 healthy year of life according to these cost-effectiveness ratios. Again, extraordinarily high value for money. But if you look at the many dollars that have been spent on HIV over the last number of years, a lot of that, it should be said, on treatment, but a fair number of dollars as well on prevention, you'd be forgiven for asking, where are all the success stories if there are so many very high-value interventions? And so I think that speaks to this concern that perhaps a lot of these published results are simply not credible and too good to be true. A second problem is that cost-effectiveness analyses often fail to focus on actionable decisions. So we tend to know, relatively speaking, a lot about technologies and their efficacies. But we know much, much less about how to deliver those technologies at scale with high quality. And so often what you see in studies, as in this example from work that the World Health Organization promoted a few years ago in cost-effectiveness analysis, is that what are prevented as interventions or strategies are actually more like target outcomes because they include some level of coverage without actually realistic specification or accounting for the policies and the operations that would be needed to achieve those target coverage levels. And I would submit to you that what would be much more useful for decision makers would be a real focus on strategies and not just technologies. In other words, the combination of a technology with some specific approach to scaling up and delivering that technology in a population at some scale. And so I think these 2 points really bring us to 2 key agenda items for the field. First, we need much more ex post analysis of cost effectiveness to add to the typically ex ante model-based analyses. And second, I think it's time for us to really get serious about integrating decision science with implementation science. And that is to say, to move from asking about the cost effectiveness of technologies, which is a very abstract way to think about things, to really asking about the cost effectiveness of adoptable strategies, including implementation specifics. And until that's done, I don't think we're really delivering on the promise of the field to provide information that's useful for decision makers. So with that as prelude, let me turn to the main topic of today's talk, which is around evaluating targeted versus generalized strategies. And it's nice to see that there'll be an entire session on this topic later on today, which I look forward to. But the logic of targeted strategies is relatively appealing and straightforward. First, targeting is hypothesized to bring extra efficiency by focusing our resources and attention on populations that are likely to benefit the most. Second, targeting is thought to also, especially with infectious diseases, offer additional benefits in terms of secondary gains. And so if we diagnose and treat people who are at the highest risk, then we might expect to have the best shot at also reducing transmission to others. In HIV/AIDS, there has been a lot of interest and growing interest, I'd say, recently in targeted strategies. This is a good example of this from Tim Hallett's group at Imperial College, a modeling study on targeting of HIV prevention. And this study sort of reasserts some of these stylized facts about targeting. But let's look for just a moment at some of the ways that modeling can go off track. And so what I'd like to do is mention a couple of the potential pitfalls that are worth thinking about and trying to avoid. And I should say that these are all pitfalls that I have fallen into, and so hopefully they will resonate with some of you as well. Pitfall number one, don't fall for the model make-believe. So what do I mean by that? Now, all models are simplifications of the world. That is their job, and that's why they're useful. But it's too easy to make the mistake of treating model conventions as if they're real. So this is an example of a very nice study that my postdoc, Ashley Tweet, had done, developing a model of gonorrhea screening in the United States. Now, in this diagram of the model, you can see that among the various stratifications of the model, one of the ways that the model is stratified is to characterize sexual risk behavior as either high activity or low activity, and those two groups have distinct rates of partner change. Now, when it comes to defining screening strategies, what we have to do is remember that what is simple in the model doesn't actually have a direct analog in the world. And so in an earlier version of the analysis, which I'm showing you here, we had a so-called focused strategy that involved intensive frequent screening among the high-risk group in the model. And without going into all of the details of this, what I want to draw your eye to is that these focus strategies, the blue bars within each of these subgroups, had much higher estimated benefits than the other strategies that we compared them to in terms of infections averted. And the trap here that I really want to emphasize is in imagining that you could actually identify perfectly some homogeneous group of the population that had universally several-fold higher risk behavior than all of the rest of the population, and you could reach them and test them several times per year. In reality, there is no such group. There is not a homogeneous group. There is not a group that's easily observable. And so in revisions of this analysis, what we've really tried to do is to map strategies to phenomena that exist in the world rather than to artifacts in the model. But this is very commonly a trap that we'll fall into. Pitfall number two, put simply, don't stack the deck. Now, models will typically capture a few mechanisms, and they will operate in a very strong causal way to drive all of the epidemiologic changes in the model. But let me give you an example here that goes back to some of the earliest modeling around the World Health Organization's global TB control strategy, which went by the name of DOTS, emphasized passive case detection of symptomatic patients, and standardized short-course treatment. So at the time that DOTS was being rolled out by WHO and promoted very hard by WHO, some modeling was done to look at the possible changes in global incidence, shown here, if coverage targets for DOTS were reached more or less quickly. And the most pessimistic scenario is this one, which suggested a rather long time course to scaling up DOTS. And that time course has actually been a pretty close proxy for what has happened in the world. It's been fairly slow scale up. But if we compare the estimated benefits in terms of incidence averted, in reality, and that's the red dots there, compared to even that pessimistic model projection, you can see that even the pessimistic projection was much more optimistic than what has actually happened. So why is that? Well, TB treatment in the model operates as a strongly deterministic causal mechanism. You treat a case, you reduce its duration of infectiousness, and you drive down incidence. In the real world, there's a lot more going on. So that brings me to the third related pitfall, and that is don't treat coverage as if it were simply a control dial. So there's nothing easier than cranking up coverage in a mathematical model. It's one parameter, it's a couple parameters. But as I mentioned earlier, you know, a lot of the WHO work on cost effectiveness has made the mistake, I think, of treating coverage as if it's an attribute of the intervention as opposed to something that you have to work to achieve and in some specified way. And these were analyses for HIV that I was involved in for WHO Choice many years ago. But you see the same sort of tendency persist today. So another study from the group at Imperial College looking at targeted strategies for HIV. And you can see here, or not, so I'll tell you what's there, that unit costs were assumed to be the same no matter whether they were applied to a targeted group Coverage was still just a parameter. So there is work that remains to be done. But let me not leave you thinking that I'm only interested in criticizing, as my teenage daughter thinks, and offer you some good news, which is that increasingly there is this work being done. And so very quickly, here's just a recent example from the TB Modeling Consortium, which was looking at intensified TB control efforts in 3 high-burden settings. And in my view, one of the best features of this collaborative was that it really did bring together epidemiologists and modelers and economists, and then forced the exercise to articulate specific strategies, to map them to effects in the model, and then, importantly, to try to assign credible costs to these. And the point that was made well by Nick Menzies and others was the point that I was just offering to you, that coverage is not just a control dial, and that costs only make sense to assign to specific programmatic activities. And so you can see here that activities needed to be mapped to strategies and to the program effects via some specified mechanisms of action, which I think is constructive. More good news is that Jim Kahn and Anna Vassal and others are working hard through the Global Health Cost Consortium, Carol as well, I think, and perhaps others who I'm forgetting, but to offer resources to help estimate the costs of TB and HIV programs, and I think that will also help us add realism to decision analyses in the field. And let me end just very quickly by mentioning a couple of empirical examples of recent work that my students and fellows have been doing, which we also hope can help nudge things forward. So Angela Chang has been working on comparing a detailed model of empirical data on movements through the HIV care cascade in a rural South African population to simple models that are closer to the conventional models in the field that assume away a lot of the cascade. And she finds, not surprisingly, that the simple conventional model can dramatically overstate the benefits of HIV treatment. David Connor has been looking at empirical data from PEPFAR countries on voluntary medical male circumcision. This graph just showing you enormous variability across countries, which I think does hint at implementation issues at local scale. And finally, a third example, Kat Andrews has been doing a detailed analysis of a kangaroo mother care program in a hospital in Mali. And kangaroo mother care, as many of you know, is the idea of continuous skin-to-skin contact, especially for low birth weight infants, to improve outcomes. That's typically thought to be one of the greatest values in global health. But in this empirical study, looking at a lot of the actual cost elements of such a program, including demand creation, training, and operations, Kat actually finds that the cost may be up to 1,000 times higher than what has been assumed in published studies. Beyond empirical work, I won't say much, but mention and give hats off to some of the conceptual work in this area. This is an example that Anna Vassal and colleagues have been doing, thinking really about this idea of strategies and constraints at supply side and demand side and at distal and proximal levels, and recognizing that sometimes interventions are needed to address these constraints. Related work by Katarina Hauk and others, sort of bringing a health system lens to this idea of priority setting and costing. And so I'll leave you here with a few parting thoughts and my attempt to distill some of the features from these various frameworks into lessons for good practice as we move forward. Thinking about elements of a realistic and policy-relevant strategy evaluation. I think that requires, as I've suggested today, a detailed characterization of intervention strategies, including specific actions, the decisions that allocate resources, the activities that carry costs and consequences, and a need to account for real-world context and consequences, both on the supply side, the health system side, as well as the patient population or demand side. A recognition of enabling conditions and resources, and importantly, the behavioral response to the decisions, information, observation, and other changes in the system. And finally, a critical look at our analytic conventions, whether that is our assumptions about the efficiency of capacity utilization or some of the modeling assumptions that I've highlighted today. So thank you all very much, and looking forward to the discussion.
All right, thank you. And if it makes you feel any better, I've just been told that the promotion does not come with a raise, so that's too bad. Our last speaker is Anirban Basu, no relation to Sanjay, and he is a professor of health economics and director of the Comparative Health Outcomes Policy and Economics Institute at the University of Washington. His research focuses on comparative and cost-effectiveness analysis, causal inference methods, and program evaluation, and he will be speaking to us today on instrumental variables to estimate heterogeneous treatment effects.
Well, let me start by thanking the organizers for inviting me. This is the first time I'm attending the conference, and I blame this tie on my neophyte status. When Jim Khan wears a tie, I do, but I stand corrected. I've been given this unenviable task to talk about the driest subject of the conference, instrumental variables, just before lunch, or at least it's not after lunch, so thanks for that too. So I'm going to talk about instrumental variables, and obviously one of the issues that we have seen throughout the day, throughout this morning, is that when we have to make decisions about the vulnerable population, we have to rely on evidence, and evidence comes from research. And the predecessor for research is that we have to have vulnerable population participate in research. And just last month there was a JAMA article that came out saying that how in this case, what NIH kind of designates as underrepresented population has not been participating in some type of research, especially clinical trials. And these underrepresented population includes pregnant mothers, mothers who are lactating, children, older adults, people with intellectual and physical disability. And these altogether constitutes over 50% of the US population. And yet there is very little evidence that they are representative in the broad range of clinical trials that are going on. Now, there have also been discussion about how do we define vulnerability, and you could look at vulnerability in many different ways. So here is another graph which comes from North Carolina, which plots the rate of the population participating in cancer clinical trials. And as you can see, only 1 to 3% of the population do participate in these trials, which is low to begin with, and we are relying evidence from that small group of people to make decisions about the entire population. But over time, we see that certain groups are actually falling behind, especially we see males and minority males especially has much lower rates of participation in these trials. So the natural question arises, obviously, is why that's the case. And there is a lot of literature which have looked at system level, individual level, and other factors that create barriers for them to participate in research. From the methods point of view, the question we need to ask is, why do we care? I mean, why do we need to have representative participation in all our research studies? And the first, obviously, there are some ethical considerations that comes up immediately, that if there is a new drug that the trial is testing out, everybody should have the equality of opportunity to try out that new drug as and when it's being tested. But beyond that, purely from the decision-making point of view, the reason we care about representativeness is because of heterogeneity. Right? And obviously, we all know, what heterogeneity is, that people are different, their outcomes are different, their biology is different, and so obviously we want to understand that we have included all kinds of people in our research. But more precisely, when we are trying to understand the effect of an intervention or treatment, what we really care about is not just heterogeneity, but effect heterogeneity. The idea that the treatment effects are different across different people. Sure, if people are different from each other, but the treatment effects are constant, we still can actually study one population and kind of extrapolate that effect to another population. So in terms of effect heterogeneity, so how do we address this idea that people are different and the effect of the interventions are different, and so how can we generate evidence for people who are not participating in research? Now, the next, there is a lot of work being done in the last 5 years about transitioning the model of randomization and clinical trials into doing more pragmatic trials. And the idea, and pragmatic trials has a lot of features to it. It's not just representation. I mean, representative enrollment is just one part of it. So what extent participants in the trial are similar to patients who would receive this intervention in real practice. But there are other factors like, it's not an efficacy trial, it's an effectiveness trial, so you should relax the constraints that are put on the trial setting. But there is a fundamental dilemma in actually doing these trials and then interpreting the results. As one of my colleagues said, sometimes we care about average treatment effect when we are understanding the effect of interventions or big policies. But when you are understanding the effect of specific treatments or specific preventive medicine, then the decision making is not at the population level, it's at the individual level. And so if we are if we worry about heterogeneity, and that's why we are trying to enroll an inclusive group of people in our research, then why is it that the average effect from from coming out of this research is any meaningful than what we were doing in the past? If we are putting all these heterogeneous group in the research and then studying the average effect, why is that valuable in any kind of decision making in real population? So obviously, one could think that, well, at least if we include all these people in research, we can do subgroup analysis. We can actually figure out what works for some people and what works for others, what doesn't work for others. But for that, to do the subgroup analysis at the level that we really want to impact decision making, we need enormous sample sizes. Often, a traditional trial method to understand heterogeneity is a very inefficient process to figure out what works for some and doesn't work for another. So in a roundabout way, I come to this idea that, well, at the end of the day, if you really want to understand heterogeneity, we might have to rely on large observational databases. And over the last several years, there has been enormous growth of how data is being collected. I mean, there is so many novel ways that not just EMR, but wearables and other things that are collecting data in a way that's unprecedented. And the question is, how do we make use of the data and make sense of the issues, the signals that are hidden in the data for different people in the different population, including some of the vulnerable population. Obviously, as we all know, and has been repeated several times here, the biggest Achilles heel for this observation study are selection bias. That people select treatment, receive treatment based on factors that are not actually captured in the data. Or even if they are captured, we don't know if all the factors are captured or not. Actually, economists and physicians think that arrow is much bigger than many other people. But it is a serious problem. And to understand selection bias, we can think about this simple diagram where we think what we are interested in is really the effect of exposure on some outcome. And we have these confounders or factors that are associated both with the outcome and the exposure. For example, you have age. Age can affect, obviously, outcome, but age can also affect whether you choose to select a treatment or not. Similarly, you can have disease severity affecting both of them. The fundamental problem of evaluation is that we don't observe all the confounders. If we had observed all the confounders, we could have controlled for that using regular statistical method. Right? And because we do not observe for it, this association that we see in the data, even after controlling for these factors, are spurious because it's driven by some of these confounders. So here comes a technique that's prevalent for over 100 years in the econ literature, is called instrumental variables. And the idea of instrumental variables is that we find some natural experiments going on in the system, in the society, that would influence you directly to take your treatment, or change your probability of taking the treatment. And this is a testable assumption because you can directly observe in the data. But this instrumental variable, or this natural experiment, by definition, is unlikely to have any direct link to outcomes. Now, this is an untestable assumption, but there are some necessary tests that people have done to show not only some instrumental variables have phase validity, but also they actually pass those necessary tests to say that this is a good instrument. In some of my other work, I have shown that actually, the instrument doesn't need to be perfect. If your selection bias is too big, even an imperfect instrument can actually give you better results. So, so in the interest of time, what I'll say is that the issue with instrumental variable is that obviously it cuts this link between disease severity and age and helps you estimate a causal effect. But when the treatment effects are heterogeneous, that means these confounding factors are actually moderating the treatment effect. This instrumental variable pushes some people to change their treatment decisions, and the effect that you're getting are only for those people who choose to change their decision because of the instrument. And as a result, just like clinical trials, those who choose into the clinical trials, their effect, average effect, does not generalize to the population. The instrumental variable effect sometimes may not generalize to the population. And there is a lot of word salad around this problem, as Sanjay mentioned. For example, there is this local average treatment effect, that is when you have two levels of instrument and you push somebody to take treatment because of the instrument level, the average effect is only for those people who change their decisions, and because treatment effects are heterogeneous, that average effect does not generalize to the population. Now, one area of work that has been particularly useful over the last actually 20 years is trying to overcome this problem using strong continuous or multi-valued instruments. And here the idea is that when you have a lot of levels of the instrument, then you can use each pair of that level to estimate something called the marginal treatment effect, or the people who are at the margin based on their observed confounders and instrument are exactly balanced with their unobserved confounders, that they are indifferent between choosing between treatment or not. And then a small perturbation of the instrument can move you, or a nudge can move you to the other side. And so there is a lot of work that's done where you can use continuous instrument to actually understand and establish treatment effect heterogeneity in the population, and even so take that and estimate a person-centered treatment effect, which is the average treatment effect for each person in your sample. And once you get that average treatment effect on each person in your sample, you can do a lot more in terms of policy evaluation. You can understand who would benefit and who would not. You would understand correlation between different outcomes in terms of the effects, and all kinds of policy evaluations that you can think of. In the last 2 minutes, I'll give you a couple of examples. One is the study on understanding the heterogeneity in the impact of school choice on adult health. So this was a big UK study in the 60s. There was a whole system change of schooling, and we used an instrumental variable analysis based on local area concentration of schooling types to instrument what they chose, and to see the effect on long-term health, so at age 23 and 33. And I'll give you two figures. So in this figure, each dot is a treatment effect for every person in our sample. And on the x-axis, you have the treatment effect on the probability of smoking at age 23, and here is the probability of smoking at age 42. So this is the effect on the probability of smoking. So positive effects means the intervention or the schooling system has increased the probability of smoking. What we found is that individuals who increase probability of smoking due to schooling at age 23 are the same individuals who continue to have a higher probability of smoking at age 42. So there is a positive correlation, although that didn't reach significance. But what's fascinating is that when you look at the effect on smoking and effect on depression at age 42, we see that people who had increased probability of smoking due to the intervention were the same people whose probability of depression increased at age 42. So the effects, you can see the correlation in the effects. The other example, and this is basically taking the individual effects and seeing the correlation over time and across different outcomes. The other example is still an ongoing example where we try to estimate the effect on intensive care units. And here, this is also UK data. Somehow, UK data has good instruments in it. They actually measured the actual number of beds available at the time of assessment, which determines whether they're going to be moved or not. And because the actual number of beds was totally outside in the realm of whether the outcome of the patient that was in the ward, we could use that as an instrument. And there, what we find that for all patients, moving them to the ICU has, on average, a positive, this is 7-day mortality, a reduction in 7-day mortality. But interestingly, those who stay back in the ward versus those who were moved in the ICU, the difference in effects is different. Those who were moved in the ICU had a much bigger effect of reduction in mortality by going to the ICU. So there is a positive self-selection in practice that you can actually see by observing and studying this heterogeneity as who is getting moved and who is getting not. And again, you can do a bunch of subgroup analysis in this case in terms of age category and for clinical characteristics. You can do this in terms of combining different subgroups, different levels of the factors, and have understand who is going to benefit from the intervention and who is not. So I would conclude by saying that advanced IV methods, when applied to real-world data, can address some of the issues of generalizability and heterogeneity. There are some requirements for the type of instrumental variables that you need. And it can serve both as a hypothesis testing kind of conduit for some subgroups that you have the sample size for. But it can also do an excellent job in generating hypotheses so that actually you can carry out future research focusing on those targets. I think in healthcare, good IVs can be found. That's what I have found in my work. But I think the bigger thing, the more important thing is that because we have such good methods to understand that if we can randomize, so IV is a method of randomization, that we should be thinking about placing these randomization methods or creating this IV when generating system level interventions. And one way that we could actually improve that is to think about continuous encouragement designs or other ways where we vary the encouragement or that nudges continuously across the population. All right, thank you.
Thank you. I'm going to ask our speakers to come up to the front so we can get the Q&A started. And while they're on their way up, I'm going to make sort of a meta comment about doing research in this area, looking at the effects of interventions and policies on vulnerable populations, which is why we're all here. And that's that this work is often politicized, and that many of us who do this research are sort of anxious about being accused of being ideological or, God forbid, unscientific. And it's exactly for this reason that careful methods like these that provide maybe more rigorous, more defensible science are important in the work that we do to help the field move forward and to help our work be taken more seriously. So on that note, we have a couple of microphones going around, so raise your hands and we'll move on from there.
I wanted to ask Mr. Dow about this idea of bias And it struck me that these countries were being evaluated based on Gates Foundation or Western medicine, and that, that their beliefs were being trivialized and discriminated against by being called biased, because that just meant they didn't agree with the Gates Foundation goals, and that people have their beliefs and cultures and faith, and of which I consider myself a minority in the United States. And anyway, as people who want to protect and encourage vulnerable populations, could you discuss the effective bias of the funders and researchers?
Yeah, that's a terrific point, and we have to be very careful with our language. I think that it is very possible for projects such as these to be driven by Western values in some sense and disrespect the local values in some of the places where we're working. But at the same time, much of the evidence for the quote-unquote bias is coming from the populations themselves who are reporting that there's unmet need. So we have interviewed many youth in these different settings who tell us that they're being treated disrespectfully, that they're being told that they won't be given certain types of things, et cetera. And so I think it's extremely important to go to the source, to the populations themselves that we're concerned about, and hear in their own voices. But it's an excellent point.
Many people will say that CEA really should be the ideal world, right? That we're supposed to analyze what could occur. Now you're arguing that we should look at what really will occur. And I think there's a lot of debate regarding which way you should be doing these. And have you gotten a lot of pushback on that, and people saying, theoretically you're doing it the wrong way, and you're going to confuse things by doing that?
Yeah, it's a great question. Thanks for that. I'm sympathetic to that perspective, but I think what convinces me that continuing to do it the way we've been doing it is not that productive is the worry that we may well conclude that something is very high value if we sort of abstract completely away from how easy or hard it is to deliver it in the real world. And then that can lead to prioritization of that and resource flows into that that ultimately just can't be translated into actual health gains. And so if everything is sort of equally hard to deliver, then it's sort of fine to idealize and think about, say, ranking and choosing in that idealized setting. If things differ, as I strongly suspect they do, in terms of how easy they are to implement and deliver, then we could well just be giving guidance that doesn't actually pan out in the world. And I think in the end, we probably need to be balanced, and I think there is a value to thinking aspirationally about where we'd like to be and what would be the choices we would make if we could fix the things that we want to fix about health systems and delivery systems. On the other hand, I feel like we're at a point now where the results really are so far abstracted away from the sort of ground realities that they are not as useful as they ought to be.
What is the utilization of health services by 15 to 18-year-olds that aren't married or pregnant? So that's one question, because my understanding is, a decade ago it was very hard to figure out how to get young, kind of pre-adolescent or young adolescents into health facilities. And then a question for you, Arnaban, is do you have to have very large sample sizes for this methodology that you were describing?
So in terms of the project that we're working with youth, 15 to 18, you're talking about, so that range. This project is particular on family planning. And you're right that a lot of youth are not going into the family planning facilities. And what we're hearing is that a lot of them say that they would like to get family planning, but they are under the impression from their friends and others in the community that they're not going to be received well. And so this is part of this sort of vicious cycle that folks are trying to break.
I would say, yes, large sample size compared to the typical clinical trials. Instrumental variable in general is an inefficient method because it throws away a part of the variation and only focuses on the exogenous part. And if you're doing subgroup analysis, you would need more. But it also depends on whether your goal is hypothesis testing or hypothesis generation. Obviously, if you're doing the hypothesis testing, you need the relevant sample size to do those hypothesis tests. But if it's generation and that's the only data you have, you could still actually look at those using smaller sample sizes.
IV is a method that's near and dear to my heart, so I'll say that I think one of the advantages is that you can use these observational data sets that are pre-existing and large so that you don't have to worry as much as you would in a clinical trial about, going like every extra person that you have to enroll to get to the subgroup effects you want to study.
Sanjay, I have a quick question for you. I want to start out with saying, as a lifelong devotee of XKCD, if I needed any other excuse to make your work more admirable, this was it. Those were the cartoons. If you don't follow XKCD, you're missing out on the best part of life. I have a question that and you may have explained this and I missed it. So we started out with that suspension of disbelief that the blue pieces won't matter, which was that there are no intrinsic differences in those formulae that you put up between the people who are enrolling and disenrolling. Is the idea then that as we go through the bounding analysis in that third step, by the time we get to the instrumental variable, we've adjusted for some of that, or did we remain suspended?
Good question. The method is so non-parametric as to say that we will bound the degree of selection in one direction or another through that first assumption. And so if you don't have that, you can still use the other assumptions and bound, but what I presented was kind of the ideal case in which you can reasonably put in all three. So the method doesn't necessarily require all three. Combinations can be used.
Hi, my question is for Mr. Dow. It's like, from my experience, I come from India and I have seen that the providers, their characteristics, especially, there is an imbalance of information and their characteristics decide whether to offer and how to offer. And it's mostly like, what I have seen is that the providers, their age, their surgical expertise or their knowledge base decides most of the time, in my personal experience, I don't know if there any evidence or not, but that is what I've seen that decides about family planning. So I was just wondering, there any work going on those characteristics and being seen that how the providers are affecting, their age may be affecting, not in this study you didn't find the age of the patient is having an impact, but maybe the age of this provider is having an impact on these decisions?
Yeah, great question. And there's sort of many hypotheses about what's driving these decisions. And there is some empirical literature out there, but it's relatively limited. We have looked at the characteristics of the providers. And we've sort of gone through a very data analytic segmentation process, or developed 6 different types of providers that have different types of characteristics that might predict what types of programs and interventions with the providers may be most effective. The age of the provider wasn't necessarily the most salient of the characteristics. So even some of the younger providers hold very pronatalist attitudes, or other types of attitudes. So that is one of the potential factors, but there were other factors that had to do with just how sort of traditional and progressive their beliefs were in general, their religious beliefs, and some had to do with how much time they're spending around young people, and that's correlated with youth to some extent. But when you're talking about 15-year-olds relating to even a 25-year-old provider, that's enough of a gap, especially in a more hierarchical society, that it's age isn't the number one. But it's an interesting question. Yeah.
What do you think about the black spot of research in Africa regarding the lack of data and the lack of good research, particularly for non-communicable disease like cancer. How can we address this problem? And what do you think? What do you think? Do you think that the research from Africa can help to solve some unresolved question from the developed world?
Wow, that's a loaded question. Well, I think to some extent, and I must admit, most of my work has been in the context of the U.S. Only recently we have done some contingent valuation exercises in Africa. I think at the end of the day, you need data, and as a person who's inclined to data sciences, although this term is now very popular, but we have all been data scientists for a long time. It's very hard to say how to do evidence-based policy without data, and any way we could help collection of that data, I think would be the first step to really say anything about what to do. And the next step, once you collect the data, is to now the curation of the data and all these statistical analysis, like what signals can you get out of it. But if you do not have the data, I mean, there is nothing much we could do except for making big assumptions. So I would say that even at the local level, ways that we could document and keep histories of data, of evidence, would be a great way to start developing infrastructure where it's a learning system where you have the data and then you can fall back on it. I think your other question about what we can learn, I think we can learn a lot depending on what the processes were in kind of overcoming some of the challenges that other places, similar places are facing. So even if the epidemiology and the biology and the genomics may not be exactly aligned, the research processes could be easily transferable to many other places.